discussed and said today, so the first-line treatment choices are really impacting the most the disease course. So choosing wisely in the first-line setting is of paramount importance, and this is based on biomarker testing. So we know that the patients should undergo testing for HER2 status, mismatch repair, PD-L1, and nowadays Claudin 18.2. So this is really crucial to select the best treatment option. There are also other trials ongoing to really test whether, for example, the addition of zolbetuximab to chemoimmunotherapy regimens may further improve outcomes because, of course, there may be some overlapping between biomarkers. So as we already do for HER2-positive disease, by combining anti-HER2 monoclonal antibodies with immunotherapy, the future for the treatment of gastric cancer may rely on combinations of monoclonal antibodies, immunotherapy, and targeted agents. And hopefully in the future we will be able to de-escalate even the chemotherapy intensity or shorten the duration of chemotherapy by the availability of effective targeted agent combinations. So I think the future is bright also because other agents are on the horizon. So for example, ADCs are already a reality, and trastuzumab deruxtecan is approved in the second-line setting and beyond, but it's commonly used after trastuzumab first-line therapy failure. And other ADCs are on the horizon. For example, Claudin 18.2 targeting ADCs may provide a good sequence starting from zolbetuximab and chemotherapy to Claudin 18.2 targeting ADCs in those tumors with high Claudin expression or positive expression. And TROP2 ADCs are also being investigated in phase 3 trials, and novel agents such as bispecific monoclonal antibodies will be key to really bring novel mechanism of action in this difficult to treat disease. And so there is a lot going on in gastric cancer, and this is good news for patients. Hopefully we will see other positive phase 3 practice changing trials, but from ASCO GI, I think that we saw a lot of interesting studies.